My name is Ashley Cruz, and I am a nurse practitioner student in Nurse 518 at Athabasca University. Please continue watching to listen to a history presentation that would take place between myself and my preceptor in the clinical setting. J.A., or Mr. Adams, is a 17-year-old Caucasian male who presents to the clinic on a non-urgent basis with a 4-day history of severe sore throat, fatigue, fever, and dysphagia. He has been unable to attend school and is worried that missing class and being unable to catch up on homework will jeopardize his ability to write his midterm exam in a few weeks. This is the first visit in recent months for this patient. Mr. Adams' symptoms of severe sore throat, fatigue, fever, and dysphagia begin 4 days prior to this clinic visit. He describes his pain as sharp, constant, and worse with drinking or eating. He has been using acetaminophen, extra strength, 2 tabs 2 to 3 times a day in conjunction with ibuprofen 400 milligrams 2 to 3 times per day. This has provided him minimal relief of his pain. He states that his girlfriend had similar symptoms 6 weeks ago where she was diagnosed with mono. He denies any other contact with sick persons. Upon meeting this patient, I did not observe any acute respiratory distress that would suggest airway compromise due to the sore throat and any associated swelling or inflammation. Mr. Adams does not take any medications on a regular basis. He denies smoking or any other illicit drug use. He also denies the use of alcohol. He has only been taking acetaminophen and ibuprofen for the past 4 days to treat the fever and attempt to achieve some pain relief. He states that he has an allergy to penicillin that was diagnosed as a child, and this allergy is characterized as breaking out into a macular papular rash. Mr. Adams lives at home with his mother, father, and younger sister. He has been dating his girlfriend for the past year. There are no reported medical conditions at present. Upon reviewing Mr. Adams' chart, it appears that he has experienced strep throat twice in the last 3 years and otitis media once as a child. The patient's last visit to the clinic was 6 months ago for a physical checkup prior to starting competitive sports at school. His general appearance, he appears fatigued, but there is no acute respiratory distress noted. He's pale with flushed cheeks. His vital signs are as follows. His temperature is 38.8 degrees Celsius, pulse is 109 and regular, respiratory rate 18 and regular, SpO2 98% on room air, and his blood pressure is 119 on 85. After examining his head, ears, eyes, neck, and throat, I did not note any conjunctivitis. There is no evidence of red or bulging tympanic membranes bilaterally. The patient was noted to have some mild rhinorrhea, but when asked, he states it hasn't been bothersome. There is visible swelling bilaterally of the patient's neck. On palpation, the patient has multiple soft, tender, mobile nodes bilaterally in the tonsillar, submandibular, and posterior cervical node regions. Each node is approximately 1.5 to 2 centimeters in diameter. On inspection of the mouth, the tongue is dry and the posterior pharynx is erythematous, with swollen tonsils bilaterally with a grade 2 for size. There is no excess saliva or drooling noted. There is moderate amount of white exudate on both tonsils. The uvula is midline, it's red but it's not swollen. Upon auscultation of the patient's chest, there is clear air entry bilaterally. His respiratory rate is 18 and regular as mentioned earlier, and there is equal expansion of the chest. The trachea is midline, and percussion reveals resonant sounds and no evidence of consolidation or fluid accumulation. I did not complete voice transmission tests at this time. I did auscultate bowel sounds, which are present, and there is no tenderness upon palpation of the liver. I am unable to palpate the spleen. Percussion demonstrates that the liver and spleen are both in proper anatomical positions, and auscultation reveals no friction rubs or venous hums. In summary, Mr. Adams is a 17-year-old male presenting to the clinic with a 4-day history of fever, fatigue, severe sore throat, and dysphagia with minimal relief from over-the-counter analgesics. He has no significant past medical history and he does not take any medications on a regular basis. He was found to have an allergy to penicillin as a child in which he breaks out into a rash. His vital signs remain stable aside from the fever of 38.8 degrees Celsius. The physical exam reveals no acute respiratory distress. However, there are swollen, mobile, and tender tonsillar, submandibular, and posterior cervical lymph nodes. He does also have a red pharynx. The tonsils are swollen and are graded as 2 with the presence of white exudate. I am unable to palpate the spleen, and the liver remains in good anatomical position. Thus, there is no reason to believe there is enlargement or inflammation of these organs at this time. In the clinical setting, I would now move on to discussing with my preceptor any information that I may have missed and would discuss how to further manage this patient with diagnostic tests and develop a plan of care. However, for this assignment, we will not be going into these details. Thank you for watching.